Esteemed members of the profession, good evening. Welcome to today's webinar. If you can hear me, just send a message on the chat and let us know which branch of PSK you're joining us from. I see some messages are coming in. Good evening, Dr. Francisca, Dr. Okumu, Dr. Ian, Dr. Evans, Dr. Gregory, Dr. Albert, karibuni sana. Thank you for your responses. I can see you can hear me. Just let us know which branch you're joining us from. Asanteni, Dr. Beatrice from Nairobi, Dr. Rubin, karibu, Dr. Abdinur from Northeastern, Dr. Ali from Coast, Dr. June from Meru branch, karibuni sana, Dr. Anthony Gitonga from Coast branch, Dr. Joshua from Western, karibu. So as we wait for our colleagues to join in, kindly ensure you subscribe to all the webinars that we've had before. Ensure you subscribe to all the webinars that we've had before. This determines how fast you'll get your CPD points. So kindly subscribe. And specifically for this event, just search on the PPB portal using the keyword Rivaroxaban, and you'll be able to find this event on the PPB portal. So kindly take your time, go to the PPB portal and subscribe for this event. Responsible use of Rivaroxaban. Thank you for joining. I see most of the branches are represented. Dr. Patrick from North Rift, Dr. Conrad from Central Rift, Dr. Lucas from Nairobi. See South Rift, Dr. Fantas. Karibuni sana. Dr. Haron from Kisii. Karibu. As we wait for our colleagues, kindly ensure that you subscribe on the PPB portal. The search keyword is Rivaroxaban, and you'll be able to find this event. And also remember to subscribe to our previous webinars. Remember, the earlier you subscribe, the earlier you receive the CPD points. So kindly subscribe early. So I see we are at 350 now. So we'll just get started. Welcome to today's webinar, which is titled Responsible Use of Rivaroxaban. And our sponsor today is Bayer, East Africa. So our speaker for today is Dr. Isaac Kamau, who's the medical advisor for Bayer on cardiorenal in the region of Southeast and West Africa. So once again, to remind you, kindly subscribe on the PPB portal. The search keyword is Rivaroxaban. Just a few ground rules. First, it's to thank you for participating in this event and to remind you that you'll be muted during the entire course of this webinar. If you have any questions, kindly use the Q&A tab, which is at the bottom of your window, and the presenter is going to respond to the questions on the Q&A tab. For PSK members, again, kindly subscribe on the PPB portal so that you can get your CPD points after this event. Remember that this session is being recorded and it will be made available on the PSK YouTube page after this. Just the agenda for today. My name is Ezra Munyakin. I was giving the opening remarks. And next we'll be having our facilitators from Bayer, Dr. Isaac Kamau and Maureen Chege. And then after that, we'll have the Q&A tab, the Q&A session that will be run by my colleague, Dr. Godwin Monroe. Then thereafter, we'll have closing remarks from Bayer and PSK. So at this point, I'd like to welcome our speaker for today. That is Dr. Isaac Kamau.
Thank you, Hezron. Good evening, everyone. Thank you for taking time out of your evening to join us for this talk. As has been mentioned, my name is Dr. Isaac Kamau, and I am the medical advisor for Best Africa Limited. So just jumping right into it, please let me know if you can see my screen.
Yes, we can see.
Good. Just good. So as has been mentioned, the title for today's talk is Responsible Use of Rivaroxaban. And this is going to be our agenda. I'm going to take you through the essence of why you need to have responsible use of an anticoagulant. We're going to cover a brief history on anticoagulant development and then look at the indications for rivaroxaban as well as each indication's appropriate dosing. And then another important aspect that I would be remiss to miss out on is anticoagulant switching and missed dose management, and we'll close it off with bleeding risk and its management. So why is there a need for responsible use? I know you know the several brands of anticoagulants that are available in the market, and they are effective agents for the treatment and prevention of thromboembolic disorders. However, finding the balance between anticoagulant effect and mitigating the bleeding risk is a delicate balance. And inappropriate use of an anticoagulant may cause potentially life-threatening bleeding. So physicians and pharmacist-led anticoagulation clinics need to assess the benefit and risk balance for any patient before initiating anticoagulant therapy. And you as healthcare providers, as well as the patients you tend to, can receive and have access to a wide range of materials from there that provides relevant information on the safe and responsible use of rivaroxaban. Your role as a pharmacist in thrombosis management is important. There have been several studies that show the benefits of pharmacist-led anticoagulation services in reducing the occurrence of VTE and managing bleeding complications, all the while with the aim to reduce excess hospitalization and healthcare costs for your patients. By taking up the responsibility, you can ensure that at-risk patients receive the correct drug at the correct dose and for the correct duration. This starts from outpatient and continues on with follow-up whenever they come, let's say, for example, to fill in another prescription, or if there has been a need to change the anticoagulant. So it's always important that you check the therapy appropriateness, check the dosage, check the duration of therapy, and assessing any drug-to-drug interactions that they may have. This can be done through educational and collaborative efforts among you as a clinician and the patient. As a person who actually follows up on your patients, you're in an ideal position to facilitate achievement of VTE-related performance measures. You can contribute substantially to improvement in current VTE care, and it's important as well to note that you can improve patient adherence. So just a brief summary in terms of early anticoagulant development. So in 1918, that's when heparin itself was first isolated, but it wasn't up until 21 years later where it was approved for use. And then in 1954, you know, the famous drug now, warfarin, was found and provided a better alternative as it's an oral medication. So there's no requirement for injections for the patients, which is a good shift from heparin to warfarin for all patients who require anticoagulation. But it does have a couple of drawbacks. It has a narrow therapeutic window. The onset and offset of action is a bit slow, and it has multiple food and drug interactions with potentially around 600 potential drug interactions that we can actually get when a patient is taking warfarin and other medications. Then there's also the need for regular coagulation monitoring. So these drawbacks necessitated a need to look for a better alternative in terms of your anticoagulation therapy. And what would an ideal anticoagulant be? Preferably administered orally with a wide therapeutic window, fixed dosing regimens for ease of adherence for the patient, no need for routine coagulation monitoring. In that regard, you're saving them time and you're saving them the cost of having to do regular checkups and lab testing. Ideally, it should be something with a quick onset and offset of action, low risk of food and drug interactions, and preferably once daily dosing. And of course, paramount to all this is a good balance of efficacy and safety. So generally, anticoagulants can be broadly categorized into 3 regards. So there could be the ones that interfere with the initiation of coagulation itself, such as tissue factor or factor 7A complex inhibitors, or those that interfere with propagation of coagulation, such as your indirect antithrombin inhibitors and direct inhibitors of factor 10 or 9A. And then also those ones that inhibit thrombin activity. So just a quick look at where they all fall. You'll find that in the coagulation cascade, you have a common pathway which starts with factor 10A, and that's where rivaroxaban comes in. So rivaroxaban is a fast oral direct factor 10A inhibitor. It has high selectivity and inhibits thrombin generation by inhibiting free and fibrin-bound factor 10A, as well as having an indirect effect on thrombin-induced platelet activation. The original drug, Xarelto, has the largest clinical trial program of all NOACs, with multiple phase 3 and phase 4 studies, with proven safety and efficacy for a wide range of cardiovascular diseases. Just a quick look in terms of the pharmacokinetics. We have 4 strengths available. Actually 5. 4. We have a 2.5 milligram and 10 milligram tablets. We have a 15 milligram tablet, and we have a 20 milligram tablet. Now, in terms of the lower dose strengths, the oral bioavailability is 80 to 100%, regardless of whether it's taken with food. But for the larger dose, the oral bioavailability under fasting conditions is around 66%. But when taken with food, the area under the curve increases by 39%, which means it's almost completely absorbed. And that's where you'll find that it's recommended when you're prescribing the 15 or 20 milligram tablets. It's important to tell your patients that this drug needs to be taken with food. In terms of distribution, it's quite highly plasma protein bound. And because of that, it's not expected to be dialyzable. And for metabolism, 2/3 is metabolized, with 1/3 being excreted and changed in urine. Of the 2/3 that's actually metabolized, 1/3 of that is half of that is eliminated renally, and half of that is eliminated through the hepatobiliary route. And in terms of half-life, it extends from 5 to 13 hours, depending on the age of the patient, with 5 to 9 hours being for young individuals and 11 to 13 hours being for the elderly. So there are multiple indications for rivaroxaban, but these are the approved 9 indications in our market. We have its use in the treatment of pulmonary embolism, and then we have the prevention of venous thromboembolism after PE, after total hip replacement or total knee replacement. There's the use in prevention of atherothrombotic events, which is the coronary artery disease, that is now termed chronic coronary syndromes or peripheral arterial disease. And then it has a huge role in the prevention of stroke, in non-valvular atrial fibrillation, and also in the treatment of DVT and secondary prevention of acute coronary syndromes. So all 9 can be broken down into 3 general categories. We're talking about stroke prevention. This is because of atrial fibrillation, where you have clot developing in the atrium. Takes a bit of time, so because the clot itself forms slowly and is fibrin rich. Then when you're talking about venous protection, this is clot formation in the bloodstream and also takes a bit of time. But when you're talking about systemic atherosclerosis, you find that these clots tend to form rapidly, and different from the other 2 that are fibrin rich, these ones tend to be platelet rich clots and form after a plaque rupture. So quick recap on atrial fibrillation. So atrial fibrillation is the most common sustained arrhythmia. And it's important to understand this because it increases the relative risk of death by about 2-fold. And the indication for rivaroxaban in atrial fibrillation is specific. It is for non-valvular atrial fibrillation, which is atrial fibrillation in the absence of mitral stenosis or mechanical prosthetic valve. And atrial fibrillation can, or rather is, an independent risk factor for stroke. It increases the risk 5-fold of getting a stroke. And 1 in 6 strokes that occur in patients with atrial, 1 in 6 strokes that occur in patients tend to be as a result of atrial fibrillation. The strokes of this nature tend to be more severe than other strokes. And even the risk of stroke is unaltered in patients with asymptomatic or intermittent atrial fibrillation. So the risk factors, this is just a quick summary. They're the ones that you can change. If you look at the diagram, if you look at rather the illustration there, in the central aspect of atrial fibrillation, there are a couple of risk factors that can't be changed. It increases as you grow older. It's affected by certain ethnicities. The male sex is more prone to getting atrial fibrillation, and there's always the risk of genetics playing a part. However, there are other things that you can change, such as lowering your alcohol consumption, avoiding smoking or stopping smoking, managing your weight, as obesity is a risk factor. There is also hypertension, diabetes, and chronic kidney disease, among others. So in terms of stroke risk and rivaroxaban's role in management, as I mentioned, rivaroxaban is the most studied anticoagulant. So we have several studies. So in patients with atrial fibrillation, we have the ROCKET-AF study, and we have XVAT, Venture, and Zarino. And then there are a couple of others for patients without atrial fibrillation, such as the Navigate, ISAS, and Galileo. But here we're just going to focus on the ROCKET-AF because that study is what forms the basis of the dosing regimen of rivaroxaban when it comes to stroke prevention in non-valvular atrial fibrillation. So the ROCKET-AF study compared warfarin for the prevention of stroke, and it looked at about 14,000 patients, either put on a 20 milligram once daily dose or a 15 milligram once daily dose, depending on the creatinine clearance. So for patients who had a creatinine clearance of 30 to 49 mLs per minute, they were put on the reduced dose. And then it was comparing this to warfarin. But in terms of the inclusion criteria, there are a couple of other things that were taken into consideration, such as patients with chronic heart failure, hypertension, age above 75 years, and diabetes. So what was found was that compared to warfarin, rivaroxaban proved to be safer, proved to be more efficacious in the management of stroke prevention. And so now you'll find that the indication we have for prevention of stroke and systemic embolism in adult patients for non-valvular atrial fibrillation with more than one risk factor, such as those ones that I mentioned. The dosing that is recommended is either 20 milligram once daily dose, again, to emphasize to be taken with food. And in patients who have moderate renal impairment, you give them the reduced dose of 15 milligrams once daily. And again, be taken with food. Moving on to venous thromboembolism. Please let me know if you can hear the sound of the video next.
Pathological thrombi can be extremely serious, causing complications such as stroke, pulmonary embolism or heart attack. Two different types of thrombi can form, arterial thrombi and venous thrombi. Here we will focus on venous thrombosis. In the slow-moving blood of the venous system, changes in blood composition, a reduction in blood flow, or changes to the vessel wall can result in the formation of fibrin-rich clots. These clots form through activation of the coagulation cascade, culminating in the factor Xa mediated generation of thrombin and the thrombin-mediated cleavage of soluble fibrinogen to insoluble fibrin. Fibrin forms long strands which are cross-linked to form a mesh that traps passing red blood cells and platelets. Over time, these build up to form a clot. If this kind of clot forms in the large veins of the leg, it is termed deep vein thrombosis or DVT. Alternatively, a part of the clot may break away and be carried in the bloodstream to the lung. If it blocks one of the arteries in the lung, this is termed a pulmonary embolism and can be fatal. In either case, clot resolution is vital because of the key role of the coagulation cascade in the formation of venous clots. Anticoagulants, which target specific proteins within the cascade, are currently the guideline-recommended treatment for acute DVT and pulmonary embolism in most patients.
Good, thank you. I hope that was clear and wasn't too loud. Now, it's important to understand the basis of VTE because it's estimated to cause about 3 million deaths a year worldwide. If we had robust tracking systems in our region, we find that probably the number is even higher. So as mentioned in the video, DVT is basically formation of a clot in one or more of the deep veins, and they tend to occur more in the lower limbs than in the upper limbs. They can also occur in other sites such as the inferior vena cava, superior vena cava, and hepatic veins. So proximal DVT refers to a thrombi that forms above the knee, and a distal DVT occurs in the deep veins of the calf. Very large emboli can cause a massive blockage if they break away from the circulation and head towards the lungs, and this could be fatal. So this is, again, just a quick picture to illustrate how an embolus breaks away and travels through the system, through the heart, and ends up lodging in the pulmonary vessels rather. So the risk factors can be divided into exposing risk factors, such as surgery, trauma, acute heart failure, and acute medical illness, or predisposing risk factors, which are basically the patient's own characteristics, such as an advanced age, obesity, immobility for a while, pregnancy, postpartum period, and hormone therapies, such as your oral contraceptives. And then there's an overlap whereby a cancer can be an exposing risk factor or a predisposing risk factor, and other inflammatory diseases. Again, just quickly looking at some of the studies, the first actual studies were done in patients after total hip or knee replacement, and those are the record 1 to 4, before we extended into the Einstein studies. So you have the Einstein PE, Einstein DVT, Einstein Extended, and Einstein Choice. So focusing on Einstein DVT briefly, this was a randomized open label, event-driven, non-inferiority study in VTE patients comparing the 15 milligram twice daily dose for the first 21 days and follow up with 20 milligram once daily dose after that, and comparing this to the standard of care, which was the enoxaparin. And then with the success of the Einstein PE and DVT studies, we looked into extended treatment, that is past 6 months of treatment with Rivaroxaban. And now this was for patients who are actually using aspirin as the standard of care to prevent any further events. So it looked at the 20 milligram once daily dose and 10 milligram once daily dose of Rivaroxaban, comparing it with 100 milligrams once daily dose of aspirin. And what was found was that in all these studies, Rivaroxaban compared to the standard of care proved again to be safer and more efficacious, although with a drawback of increased GI bleeding risk in these patients. So the regimen as it stands for treatment of DVT and PE is you start off with 15 milligrams twice daily for the first 21 days, and then move on to the 20 milligram once daily dose after that. And again, similar to the stroke prevention dose, if your patients are renally impaired, you reduce the risk to 15 milligrams. The treatment usually varies from 3, 6 to 12 months after the first event. But after 6 months of treatment, you can consider a 10 milligram once daily dose for extended treatment. This comes from the Einstein Choice study, or 20 milligrams once daily if high risk of VT recurrence is seen. These examples of this would be complicated comorbidities, or if they had a recurrent PE or DVT while on treatment. And for the last indication, we are going to look at acute and chronic phases of CAD and PAD. So again, these are some of the studies for the basis of CAD, PAD. We have the COMPASS study and Voyager PAD and Atlas study for patients with acute coronary syndromes. Now, in these studies, these studies had the lowest dose of Rivaroxaban studied, which is 2.5 milligrams twice daily, but it is done in combination with aspirin. And when you're looking at atherothrombosis, so it's basically a common denominator for coronary, peripheral, and cerebrovascular disease. And it's progressive, it's multisystemic, it's a multisystemic polyvascular disease that can lead to atherothrombotic events. And when they occur suddenly, they may result in irreversible organ damage, such as after basically causing a stroke or myocardial infection. And as you can see, it reduces the life expectancy of patients. So for patients with atherothrombosis and a history of cardiovascular disease, it's been noted that it reduces the lifespan by about 7.7 years. And for patients who had a history of stroke and have atherothrombosis, it's been shown to reduce the lifespan by about 12 years. So the essence of Rivaroxaban in this study was, as I mentioned in the beginning, it acts through two ways. So there is the fibrin effect, there's the effect that it has on fibrin, but there's also the indirect effect that it has on platelet activation. So for example, looking at the COMPASS study, which included patients with chronic coronary artery disease and peripheral artery disease, They looked at 3 doses. They looked at 2.5 milligrams twice daily, in addition to aspirin, 100 milligrams once daily. Then they just looked at Rivaroxaban 5 milligrams twice daily, comparing it to the standard of care, which was aspirin 100 milligrams once daily. And the effect that they saw was that in terms of safety and efficacy, it proved to be such a success that the study itself was stopped 1 year ahead of expectations. And in terms of the dosing that they found that worked well was the 2.5 milligram dose plus aspirin 100 milligram dose. And at this point, I want to mention something else. No two anticoagulants are the same. A 2.5 milligram dose of Rivaroxaban is not the same as apixaban 2.5 milligrams twice a day. In the Appraise trial, where they looked at a 2.5 milligram dose twice daily of apixaban for prevention of chronic coronary artery disease, or PAD, it found to actually cause much more bleeding than the standard of care, and the study itself was abandoned. So please, if you find someone who's been put on a 2.5 milligram dose of Rivaroxaban, do not think you can change it to apixaban 2.5 milligram dose for the same effect. So now we're going to look at switching from a VKA, switching from warfarin to Rivaroxaban. So when you want to switch from warfarin to Rivaroxaban, the guidance is that you stop the VKA and you assess the INR. As we know, VKAs are INR dependent. So the moment the INR is less than 3, you can begin Rivaroxaban if the indication is for SPA. But if the indication is for DVT or PE treatment, you monitor the INR up until it gets to less than 2.5, and then you initiate treatment for Rivaroxaban. Where it gets tricky is when you're converting from Rivaroxaban to a VKA. This is the only indication where you actually can have 2 anticoagulants in a patient at the same time. So what you do is you give the VKA and Rivaroxaban concomitantly, and you check the INR. Okay. So once the INR is above 2, you can stop the Rivaroxaban and continue with your VKA. The essence of this is, as you said, VKAs have a slow onset and offset of action, and they are INR dependent in terms of monitoring for effect. So you want to make sure that at no one point is your patient not adequately covered. So that's why you give the VKA and Rivaroxaban, monitor the INR. Once the INR is above 2, you stop the Rivaroxaban, continue with the VKA. So back to the main topic, back to the title, which is basically responsible use. All oral anticoagulants can cause bleeds, and they may have some drug-to-drug interactions. It's important to note this, and it's important to follow up on your patients. It's not like giving a 5-day dose of an antibiotic and you pretty much know that this patient is going to be fine. No, they need follow-up. And especially for patients who have atrial fibrillation, they're quite fragile. So it's important that whenever they come, you check for adherence, check for any thromboembolic events or bleeding, check for any side effects that they may have. And it's especially important that you look at any other medication that they may have. Then also, it's important to, at least once a year, keep checking on their creatinine clearance levels. So what happens when a patient is not adherent to their oral anticoagulant? What happens when they miss a dose? So for the once daily indications, such as PAF or VTE from day 22 onwards, they should take Rivaroxaban immediately and continue the following day with the once daily intake as recommended. They shouldn't double up within the same day to make up for a missed dose. However, for the twice daily doses, such as VTE in day 1 to 21, when they're in that twice daily phase, they should take Rivaroxaban immediately to ensure the intake of 30 milligrams of Rivaroxaban per day, so they can take 2 15 milligram tablets at once, and then continue on with the regular 15 twice daily intake on the following day. But when it comes to your ACS, you should continue with the regular dose at the next scheduled time and not double up to make up one missed dose. The essence of this is they're also taking aspirin, okay? So one missed dose shouldn't adversely affect their treatment. But if they double up, that's increasing the risk of bleeding. So just some contraindications for Rivaroxaban. There's hypersensitivity, patients with active bleeding that's clinically significant, any lesions or conditions that may put them at risk of major bleeding, such as GI ulcers or cancers, and then any recent brain or spinal surgery. And then another contraindication, as I mentioned, is if they are on any treatment with another anticoagulant, be it unfractionated heparin, enoxaparin, or other oral anticoagulants, they should not be taking Rivaroxaban. The only exception to this is when you're switching from Rivaroxaban to a VKA. And again, as mentioned, you have to monitor. The moment the INR gets above 2, you stop the Rivaroxaban, continue with the warfarin. And then other contraindications are pregnancy and breastfeeding, and hepatic disease associated with coagulopathy. And then, of course, with any anticoagulant, as I mentioned, it's a fine line. You have to assess the risk versus the benefit, because an anticoagulant will put them at a higher risk of bleeding. And this is particularly true for certain patient populations. So patients with renal impairment, patients with hepatic impairment, patients with other hemorrhagic risk factors are potentially at a higher risk of bleeding. So it's important to take note of these patients and monitor them adequately. Again, concomitant drugs, they actually thought this would be very important for the team of pharmacists here. You need to look at what other drugs are they taking. And you need to be very careful, especially with certain drugs like rifampicin, phenytoin, carbamazepine, and ketoconazole or itraconazole, or any other HIV protease inhibitors such as ritonavir. So in terms of the potential of higher risk, you'll find that patients who are on ketoconazole and are put on Rivaroxaban have a much higher risk of bleeding. Same goes for ritonavir, but when you compare it to drugs such as erythromycin or fluconazole, the risk is moderate. Then when it comes to overdose, we don't really expect Rivaroxaban patients to overdose on Rivaroxaban. So there's a certain ceiling effect where doses of above 50 milligrams of Rivaroxaban taken, that's basically the maximum that can be tolerated in the body, and that doesn't increase the risk of bleeding. But in such cases, let's say, for example, if somebody misplaced the drugs and a child got access to the drugs and took them, you can use activated charcoal to reduce absorption within the first 4 hours after intake. And then we're going to look at the bleeding management in terms of what you do if, let's say, again, a child takes the drug and they have increased risk of bleeding or even if they actually do start to bleed. So this again is just to show that all dogs, be it dabigatran, apixaban, rivaroxaban, tend to deliver more benefit than VKAs. If you look at the graph there, the only thing where warfarin is favored is when it comes to the risk of GI bleeding in patients. And again, all dogs can cause bleeding. It's the essence of an anticoagulant. So just looking at the risk of VKA versus rivaroxaban, comparing the bleeding risk. So compared to warfarin, if you look at critical organ bleeding, you'll see that the hazard ratio there is about 0.69. So that translates to a 31% relative risk reduction in terms of your risk of critical organ bleeding when using rivaroxaban as compared to a VKA. Same thing goes for your intracranial hemorrhaging and fetal bleeding. And in terms of real-world evidence, as mentioned, we have multiple phase 4 studies, which is real-world evidence to assess the efficacy and safety of a drug in the general population. So you'll find that in terms of the risk of bleeding, when it comes to case fatality rates, rivaroxaban, the data favors rivaroxaban over VKAs. And then just again, summary of the PK, now comparing it to a VKA. So this is what we were talking about looking at the short onset and offset of action of a drug versus of rivaroxaban rather, versus the onset and offset of action of a VKA. And you can see that the duration of effect for warfarin lasts up to 5 days. But when it comes to rivaroxaban, the duration of effect is at least 24 hours. So when you compare rivaroxaban to a VKA, it gives you the advantage of a quick onset of action, a shorter half-life, and sufficient duration of effect for once daily dosing. And when it comes to bleeding, now this is important as well. So there is an antidote for the factor Xa inhibitors called adexonate alpha. However, it is not locally available and it is quite expensive. So what happens when you have non-life-threatening major bleeding? So the guidance is you apply local hemostatic pressures after you found out what the last intake and dose regimen was. And then you give adequate fluid replacement and RBC substitution if necessary. You can give tranexamic acid as an adjuvant to the drug and desmopressin in special cases. When it comes to life-threatening bleeding, you have to make sure you take up all the measures mentioned in the first box, and then consider your activated prothrombin complex concentrates or your prothrombin complex concentrates. So in summary, the use of warfarin reduces the high risk of ischemic strokes in patients with atrial fibrillation, but it has drawbacks in terms that you require frequent coagulation monitoring and dose adjustment. So ROCKET-IF demonstrated that rivaroxaban provides more consistent and predictable anticoagulation than warfarin. And then the relative efficacy and safety of rivaroxaban versus warfarin is consistent across subgroups in clinical trials and in real life. So closing off, it's important to note that Bayer takes patient safety quite seriously, and we are committed to the national and international obligations for pharmacovigilance. So if there are any suspected adverse drug reactions to a Bayer medicine, kindly report it to us there's an email down there, pv.sewa@bayer.com. And in terms for the patients themselves, we have resources for them. We have patient alert cards where they can fill in their details and their dosing and for which indication. And there are also rubber bands to help identify patients on the anticoagulant in case of emergencies. Alternatively, if you can't reach us, we work quite closely with PPB, and you can take your concerns to PPB, and they will be in touch with us. As for you, as the healthcare practitioner, as a clinician, as a pharmacist, if you have any medical inquiries regarding any of our medicines, feel free to contact me at za-medinfo@bayer.com. And we also have materials for perusal. We have Xarelto dosing guides that highlights indications, dosing schemes, how to manage the missed dose, practical management, and contraindication. And with that, I want to thank you for your time. And that is the end of my presentation.
Thank you so much, Dr. Isaac, for this wonderful presentation. My name is Miles Mandro, and I'll be the moderator for our next session. So up next, we are going to have Maureen Chege from Bayer. If you could kindly present your screen.
Thank you, Miles. Good evening, everyone. Thank you, Dr. Isaac, for your presentation. Thanks, everyone, for your attention and for taking time to join our meeting. I'll just proceed to share my screen. My name is Maureen Chege. I am a medical representative. I've worked with Bayer for the last 9 years. So I shall do a small marketing presentation regarding Xarelto. So please let me know if you can see my screen.
Yes, you can go in.
Okay, great. Thank you. Yes, so what I wanted to share with all of you is, first of all, to tell you, thank you so much for supporting Bayer and giving the benefit of Xarelto to your patients. Yes, as pharmacists, you play a huge role as well, because you get to see, you're the last person that the patient is in contact with. And by giving them Xarelto by brand, you are actually part of this huge celebration for us. Currently, we have 120 million patients worldwide who are on Xarelto since we launched. This is like double the population of Kenya. And we could not get to this number without your support. We thank you very much for this. So basically what this means is that we have a lot of data within Bayer regarding the different kinds of patients who present with DVT or PE or non-valvular atrial fibrillation at the doctor's office. Because as we all know, patient characteristics are very, very different. And they present with different comorbidities. There are some very challenging patients who need anticoagulation and have been given Xarelto by brand. And of course, we have this data with us. So we thank you so much for your support. We have a lot of data that you can trust as Bayer. So Bayer has been actually available for 150 years. We have been in operation for 150 years. So we have a lot of data. We have a lot of innovative products that we have launched over the years. Xarelto specifically is the original Rivaroxaban molecule that was manufactured in Germany. We took more than 12 years to develop this molecule. And this just shows you the amount of work that our scientists have to go through to develop the brand, the molecule Rivaroxaban, which for Bayer, the brand is Xarelto. This is a molecule and a brand that you can trust. We have a lot of data, as I've just mentioned. Something that is very important to mention as well is that we have over 318,000 patients who have been involved in clinical trials regarding Xarelto. So that is a very huge, huge number of patients within our studies, which just gives you, of course, more confidence to give Xarelto by brand because we have taken a big representation of the population to give a trial in regards to the efficacy and safety of Xarelto for the different indications. As Dr. Kamau has mentioned, we are approved for 9 indications here in Kenya. He has mentioned most of them. In summary, it's just stroke prevention in patients with non-valvular atrial fibrillation and for venous thromboembolism, which is the acronym VTE, which stands for pulmonary embolism patients and of course, deep venous thrombosis patients. Therefore, there are more than 10 million cases of venous thromboembolism worldwide each year, 10 million cases. So these patients need to be protected. Of course, we all know VTE can be a very serious life-threatening condition. We need to give our patients a brand that we can trust. And as I've mentioned, Xarelto has a lot of years of developing that we have taken to develop that molecule. And in fact, every 37 seconds, someone in the Western world dies of a blood clot. So we need to give a brand that you trust. As Dr. Kamau has mentioned, for PE and DVT, once a doctor has actually diagnosed a patient with this, we start the treatment with 15 milligrams twice a day for 21 days. After this, we will give Xarelto 20 milligrams once a day from day 22 onwards. The duration of treatment really depends on the causative factor of the PE or the DVT. Treatment can be for either 3 months or up to 6 months, or sometimes the doctor might need to give extended treatment for this patient because they view this patient as a high risk. So from day 22 to 6 months, the patient is on 20 milligrams once a day. If the doctor feels like this patient needs treatment from 6 months, he re-evaluates the patient. If the risk of this patient getting a recurrence is still high, the patient is maintained on 20 milligrams once a day. But if the chances of getting a recurrence have lowered, the patient is given 10 milligrams once a day. Now, this treatment can go up to 12 months or even 24 months onwards. It all depends on the risk of recurrence, which the doctor is the one who will make the risk assessment. So if you see a dosage, these dosages, like I've mentioned, this is what Bayer actually recommends for PE and DVT treatment. For the ones who are working in institutions, sometimes the patient is admitted when they have a PE and a DVT, maybe for 5 days, and they're receiving Clexane when they're in the ward. Once you discharge this patient, we need you to also work hand in hand with the doctors to help them do the switch from the injectable anticoagulant to Xarelto. So for this patient who has been in the ward getting Clexane maybe for 5 days, what you do is that once they're discharged, you will now give this patient 15 milligrams once a day, not for 21 days. You'll take into consideration the days they've been receiving the injectable anticoagulant. So maybe let's say, for example, they've been getting the injectable anticoagulant for 5 days. You'll just do 21 minus 5, meaning that this patient should get Xarelto 15 milligrams twice a day for 16 days. So it's very important to note this change in the dosage because you don't need to overexpose the patient to Xarelto. And of course, you'll still save costs for the patient. So please take note about this switching. And how you do the switching as well is that you will now, if the patient is getting the injectable anticoagulant maybe at 6 a.m. and 6 p.m. every day, the dosage of Xarelto, they will start Xarelto now 0 to 2 hours before the next scheduled dose for the injectable anticoagulant. So maybe if the patient is supposed to get the injectable anticoagulant at 6 a.m. the next day when they're being discharged, you should give Xarelto between 4 a.m. and 6 a.m. It's very important to take into consideration the time that you give Xarelto because you don't want the patient to be either under anticoagulated where they can get a recurrent DVT, or they bleed because they have a high level of anticoagulants in their system. So for the 15 milligram and the 20 milligram, it needs to be taken with meals. We normally recommend that they take with food, because we noticed during the clinical trials for the patients who were taking Xarelto 15 and 20 with meals, the bioavailability was actually quite high, up to 80 to 100%. But the patients who took Xarelto 15 and 20 on a starving state, the bioavailability was 66%. So the presence of food is quite important. Please do remember to take note. When you're dispensing it, please advise your patient the same. For the patients who are taking 10 milligrams or 2.5 milligram, the presence of food does not really affect the bioavailability. The product, the Xarelto is actually absorbed quite well. So to make it easier for you, you can just recommend for patients on Xarelto to please take with food. It's very important. For patients who have undergone hip or knee replacement surgery, they also do receive Xarelto. For patients who have undergone hip replacement surgery, they get 10 milligrams once a day for 5 weeks. For the patients who have undergone knee replacement surgery, the patients receive Xarelto 10 milligrams once a day for 2 weeks. So please take note of the dosages for hip and knee replacement surgery. Then Xarelto, maybe in case the patient is already on Xarelto and and they need surgery, we normally recommend you stop Xarelto 12 to 24 hours before surgery, and they can resume Xarelto after 6 hours, 6 to 10 hours after surgery, as long as hemostasis has been established. But if this patient just has gone for hip or knee replacement surgery and they're starting Xarelto for the first time, you can just start once hemostasis has been established, which should not be more earlier than 6 hours. Yes, so I'll move on to the next slide. For stroke prevention in patients with non-valvular atrial fibrillation, please note non-valvular atrial fibrillation. We do recommend they get Xarelto 20 milligrams once a day for life, because these patients have a high chance of developing clots, and they need protection throughout their life. So in case the patient has a creatinine clearance of 15 to 49 milliliter per minute, we recommend this patient receives 15 milligrams Xarelto once a day for life. So please take note. Sometimes you would see a prescription from a doctor, from a cardiologist, maybe recommending 15 once a day for life or 20 once a day for life. But what I always encourage is that in case you see a prescription that you are doubting, please reach out to the healthcare provider. Sometimes, of course, we are all human beings. They might confuse the dosage. Maybe it's say 20 milligrams twice a day, which is not a recommendation from us as buyer. Please contact the doctor, confirm with them if that is the dosage they intended to give and for what indication the patient is getting Xarelto. You might actually save a life. Yes, so for Xarelto, I like also just showing you what we have. From Bayer, East Africa, we normally have Xarelto 10 milligrams in a pack of 10s, Xarelto 15 milligram and 20 milligrams in a pack of 14s. So please ensure when you're purchasing Xarelto, this is the packaging that you get. This is what is coming from Bayer, East Africa. And in case you find anything that looks contrary to this, please reach out to us so that we can assist you in regarding to inform you whether this is a genuine product from Bayer. So Bayer, Xarelto has been available since 2008. The patient numbers are increasing every day, and this support, we cannot get to this number without your support. We are here for you in case you need any information, any clarification regarding the dosages, regarding the drug interactions, contraindications. Please reach out to Bayer. We do have this information with us, and we are happy to share with you and walk the journey with you in bringing your patient back to good life. Yeah, quality life. Yes. So that's what I wanted to share this evening with everyone. Thank you so much for your time. I think now we can receive any questions. Thank you.
Thank you so much, Maureen. So our next session is the Q&A. Just a reminder, I would like to remind everyone that for any questions, kindly use the Q&A tab so that we can easily track the questions. All right. So for Dr. Isaac, we have a question here. Salim is asking whether there is benefit for use of Rivaroxaban in cancer patients.
Okay. Thank you, Salim. Yes, there is benefit for use of Rivaroxaban in cancer patients. It's just that unfortunately, it's not a registered indication that we have here. However, there are several studies that look specifically at Rivaroxaban use for treatment of venous thromboembolism or pulmonary embolism in cancer patients, and the benefit has been shown.
Okay. On to the next question. Some anonymous person would like you to discuss the Child-Pugh score and the importance before initiating a patient on Rivaroxaban.
Sorry, I'm seeing, before you move on to that one, I'm seeing Salim still has a couple of questions. So quick one, does Rivaroxaban have mortality benefits again amongst non-valvular AF patients? So the essence of Rivaroxaban in non-valvular AF patients is mainly to prevent morbidity, which is caused morbidity and mortality, which can be a consequence of them getting a stroke as a result of the clot. But the main treatments in terms of AF, it's usually rate rhythm control, because you need to treat the offending agent, which in this case is a dysarrhythmia. And that can be done through medication for rate rhythm control or implantable cardioverter devices, such as your pacemakers. And then for patients with CKD with an eGFR of 20 mLs per minute, I see that Maureen has covered that as well. So it's not recommended for use in patients with an eGFR below 15. But for patients with with a low eGFR above 15, you need to reduce the dose and you need to monitor the benefit and risk of using it in these patients. Now for anonymous attendee, could you please discuss Child-Pugh score and its importance before initiating a patient on Rivaroxaban? Okay. So one of the contraindications for Rivaroxaban is use in patients with a Child-Pugh score of, is it B or C? So the Child-Pugh score basically used to assess the prognosis of chronic liver disease, mostly looking at cirrhosis. The reason for using the score is as patients with cirrhosis and chronic liver disease tend to have a deficiency in the manufacturing of the clotting factors, which is usually done in the liver. So the essence of using the score is to assess the risk. If it's too high a risk, that means they're probably going to have an issue with the bleeding. So it's contraindicated in patients with a high risk score of the Child-Pugh.
Okay. Yes, we can just continue with Flora and Ashford.
Okay. So can it be used in patients with low platelets who need anticoagulation? Is there a cutoff level of thrombocytopenia? So it can be used. The essence is, as much as it does not affect platelet production, what it affects is platelet activated clot formation. So it can be used in these patients. In terms of the cutoff level of thrombocytopenia, I am not quite sure about what the cutoff level is there. And then I see Ashford has a question. What is the role of NOACs in artificial heart valves? So unfortunately, there was a study that was being done, and Kenyatta National Hospital took part in the study. The trial itself is called Invictus study, and it was looking at the use of Rivaroxaban in patients with severe mitral stenosis and mechanical valves. Now, unfortunately, it was found that it tends to cause more bleeding in these patients as compared to warfarin. And the current recommendation is for patients with artificial heart valves, you stick to your VKAs. Miles?
Hello, sorry. For Dr. Lucas, we have several questions. There is one in the chat where he's asking, what is Rivaroxaban's pharmacogenetic profile and what was the African representation in the studies used? And what was the outcomes and endpoints for the Africans who participated in the study?
No, that is a very interesting question. Unfortunately, we didn't have African participation in the studies. Most of the studies usually focus on Caucasians, Asians, and African Americans. And the genetic profiles, even if we share similarities between the African Americans and ourselves, the genetic profile is not quite identical. So that's an issue that we've been having with clinical studies, the lack of participation and representation in a majority of clinical trials.
Okay, we have a question for Maureen from Dr. Lucas. He's asking what was in the clinical trial, what was the N, what was the demographics, gender, age, and ethnicity, and whether there were any food and lifestyle interactions.
Thank you for the question. The clinical trials for Xarelto actually are dependent on the indication. Like for DVT and PE, we had the Einstein PE trial, the Einstein DVT trial. We had the Einstein extension trial. We also had the Einstein choice. So we have several trials for the PE and DVT studies, and we had a different representation in regards to the number of patients in the trial. Like also for stroke prevention in atrial fibrillation, it was the Rocket AF trial, which had around 16,000 patients. So for the Einstein choice, we had around 7,000 patients. So there was a different number representation for the different trials, for the different indications. In regards to age, the inclusion in the trial was patients who are 18 years and above. For the ethnicity, as Dr. Isaac has said, we didn't have a good representation for the African population. I think what the African population that we had was in the Invictus trial, which was an investigator-led trial. The centers were actually here in Nairobi, Kenyatta Hospital. In Eldoret was the Moi Teaching and Referral Hospital. In Mombasa, we had the Coast General Hospital, and also some patients in East Africa. So that was the only trial which was investigator-led, which had African population representation. And I think Dr. Isaac has also shared the results of the trial in regards to patients with heart valves. For the food and lifestyle interactions, the good thing about Xarelto is that there are no food interactions that compared to warfarin. That is one of the benefits of giving Xarelto versus warfarin. You know the challenges with warfarin. So that's why physicians prefer Xarelto over warfarin, because it's hard to actually control what food patients eat, even if you give them the advice. Yes. So in regards to lifestyle interactions, I'm not sure exactly what you mean with that question. Maybe you can elaborate. Yeah, I wouldn't want to answer if I don't know exactly what you ask in regards to lifestyle interactions. Yeah.
Okay, maybe as he elaborates, before you go, Maureen, Dr. Ayub is inquiring about the dosage in geriatrics.
Okay. So the dosage in geriatrics, actually, the beauty about Xarelto, there is no need for dose adjustments based on weight and age. what actually determines the dosage is the creatinine clearance. So for stroke prevention in patients with non-valvular atrial fibrillation, we recommend they get 20 milligrams once a day. This is even for patients who are geriatric. And what determines the lowering of the dosage is their kidney function. So in case they have a creatinine clearance, they have either moderate renal impairment or mild renal impairment. That is where the dosage goes down to 15 milligrams once a day. Yeah.
Okay. Finally, for you, Maureen, does Bayer have any market access programs to allow patients get this medicine at an affordable cost?
Yeah, thank you for that question. We are always much focused to ensure that Xarelto is available to a wide range for patient profiles. So the programs that we have currently are actually for institutions like Kenyatta and MTRH. We actually supply them directly from Bayer at subsidized prices. So for those patients who maybe are cost sensitive, we normally advise they can actually purchase Xarelto at Kenyatta. For the ones in Nairobi, they should get it for a tablet, should be around 69 shillings for a tablet, compared to the open market, which should be between 140 shillings to 180 shillings, yeah, depending on the markup. So we do have market access programs for these institutions based on their profile of patients they receive. And we also have a subsidized price. We do actually supply meds. So of course, meds supplies most of the counties in case they're not able to purchase from KEMSA. And they do have the same price range as Kenyatta. So the patients normally, for an institution who wants to buy from meds, they'll get Xarelto at 69 shillings. Yeah, for a tablet.
Okay. Back to Dr. Isaac. There is a question here whether Rivaroxaban can be used in the management of maternal VT prophylaxis after C-section delivery. And maybe also while you're answering, you could touch on the safety of this drug in pregnancy.
Okay. So that they actually do align both questions. So Rivaroxaban is contraindicated in pregnancy and in lactating women. So for after C-section delivery, it's not recommended for use for VTE prophylaxis.
Okay. One final question. Sorry. Okay. There is a call out that there needs to be by Dr. Lucas on how we can be able to extrapolate further studies to our ethnicity and encourage and ensure African patients are represented. Yes. So having no further questions, maybe you could give closing remarks, Dr. Isaac.
Thank you very much for your attendance, and thank you very much for the very interesting questions. It shows that you are paying attention and you are very curious in regards to how to help manage your patients safely, how to take responsibility for their care. And if you do have any other further questions, please feel free to reach out to me at the email address that I showed you. If you have a pen, paper, it's pv-sewa, S-E-W-A, @bayer.com. And I would gladly answer any questions that you may have and provide any further information you may require. Once again, thank you.
Okay, over to you, Maureen, for your closing remarks.
Thank you so much. Just quite humbled by the huge number of participants and the active participation and the questions. We really do highly appreciate it. Dr. Isaac, I think I can see there's a few other questions in Q&A. Maybe you can go through them quickly before we hand over the meeting. But thank you so much for the participation and the opportunity to engage with you. We highly appreciate it.
So, Miles, if you'll allow, maybe I can just start on three questions here.
Yes.
Okay,
Yes.
thank you. So, is Xarelto 2.5 milligrams one of Bayer's products registered in Kenya, and when is it recommended? So, there is the 2.5 milligram strength of Xarelto registered in Kenya, and the indication is for acute coronary syndrome or coronary artery disease or peripheral artery disease. And it's taken twice a day, 2.5 twice a day, in addition to aspirin 100 milligrams. And I'd like, again, just to remind you, 2.5 milligrams of Xarelto is not the same as 2.5 milligrams of apixaban. So if the indication is for ACS, PAD, kindly be careful in terms of your next steps. Then I see a question from Victor Ungeri, DVT in FP. I'm assuming that's family planning. So yes, hormonal contraceptives have been shown to increase your risk of developing a DVT. And the good thing is it's a modifiable risk factor. So usually if they develop a DVT, you can use Rivaroxaban using the same regimen treatment. However, it's important to note that you'll have to consider stopping the family planning. Usually once you take out the family planning, the risk goes down to normal within about 3 months. And then, is apixaban a safer option for patients with severe renal failure? Interesting. So Rivaroxaban has been shown to have a good safety profile and a good efficacious profile as well. Again, in this regard, I'll just advise you that Rivaroxaban is not recommended in patients with a creatinine clearance less than 15, and for patients with above 15, but with moderate renal impairment. It's important that you monitor the risk. It's important that you monitor the risk. And I think, yeah, and I agree with you, Dr. Lucas Nyebero. We do seriously need to consider how we can get into studies and extrapolate results for ethnicities. And I think with that, I am done.
Thank you so much, Dr. Isaac. Is Dr. Jane on the call? Dr. Jane? Maybe you could send an email to Dr. Isaac's email. Maybe we can post it on the chat. Is it possible, Dr. Isaac, to post your email on the chat so that attendees could be able to maybe contact you in case of any further questions?
Okay. I'm just opening it in right now. So for medical inquiries, the address is za-medinfo@bayer.com. And for any PV concerns, I can see that it's already been added by a colleague, pv.sewa@bayer.com.
Okay. Thank you so much. So as we close this session, I would like to make a few announcements. On December 2nd, we'll be having our PSK Nyanza branch symposium. So if you're from Nyanza branch or anywhere close to Nyanza, please, you can be able to attend. It's going to be on 2nd December from 8 to 5 p.m. at Tarova Imperial Hotel, Kisumu. Again, due to public demand for our end of year dinner and dance, we have a few extra tickets available. Deadline is tomorrow midnight. So if you wish to attend, kindly purchase your tickets and send payment confirmation to this number. Also, on December 2nd in Nairobi, we'll be having our pharmacy skills workshop. It's a training that is also CPD accredited. You are advised to also get your tickets for this event. And thank you so much for your time. Thank you so much for listening in. Remember to subscribe on the PPB portal so that you can be able to timely share to share the CPD points. Yeah, and I would also like to thank Bayer for sponsoring this event. Special mention to Dr. Jayesh Pandit, who is the pharmacovigilance country head at Bayer. All right, thank you so much. Thank you for listening in.
Thank you, everyone. Have a good evening.
Thank you. Good evening.